Today's lecture will be about the elbow ultrasound. Um, we'll discuss also the technique and the common pathologies. We examine the elbow joint anteriorly, medially, laterally, and posteriorly. We start the examination anteriorly by applying the probe TS, where we see the distal humerus, the capitulum, the trochlea. The muscle in the middle is the brachialis. The one at the radial side is the brachioradialis, and the other one, the medially, is the pronator teres. The brachial artery is an important landmark. Medial to it is the median nerve, and lateral to it superficially is the biceps tendon. It starts superficial at the elbow, then as we move distally, it takes its course to insert into the radial tuberosity. This is another image of the median nerve, medial to the brachial artery, and the biceps tendon lateral to it, with the brachialis muscle and the pronator teres muscle. Then we move the probe to LS orientation, where we examine the distal biceps tendon down to its insertion into the radial tuberosity. We can ask the patient to do an external rotation, or take his hand and do an external rotation to stretch the tendon and do a proper examination. This is the distal end of the biceps muscle, the brachial artery, and the pronator teres muscle. Sometimes this technique does not work, so we can use another one, which will be discussed in the next slide, in order to properly visualize the distant part of the biceps tendon. In this other technique, we ask the patient to bend his elbow 90 degrees. Then we put the probe at the medial aspect of the humerus, moving it downwards till the elbow joint, with slightly moving it anterior at the region of the elbow joint. This technique will help us to see the pronator teres muscle. Then this is the pronator teres muscle. Then we try to locate the brachial artery and use it as a window to visualize the distal fibers of the biceps tendon till its insertion. Then we can also do a dynamic examination by doing an internal rotation of the forearm, where we can see the movement of the tendon properly. Moving on to the examination of the medial elbow, we put the probe LS at the medial aspect of the joint, where we see the common flexor tendon. Slight manipulation at the joint will help us to see another thin ligament beneath it, which is the ulnar collateral ligament. This is the common flexor tendon, also seen in this scan. If we examine the posteromedial aspect of the elbow joint, we can examine the cubital tunnel, where we can see the ulnar nerve. And by moving the probe slightly distally, we can see the flexor carpi ulnaris muscles, the ulnar head and the humeral head, with an arcuate ligament seen between them. This arcuate ligament is one of the sites of is the second site of entrapment after the cubital tunnel of the ulnar nerve. So it can be entrapped at this site of the under arcuate ligament, or in the cubital tunnel. The causes of entrapment may be the ulnar nerve subluxation, the presence of a ganglion cyst, an osteochondroma, or an accessory anconeus muscle, or thickening of the arcuate ligament. Then we move to examination of the lateral elbow. We can examine it while the patient is sitting and bending his elbow, or as the medial aspect on extension of the elbow. Here we see the common extensor tendon and another ligament seen deep to it, which is the radial collateral ligament. Then we examine the radial nerve. We just put the probe at TS position at the lateral aspect of the arm. The only nerve seen at this area is the radial nerve. Then we trace the nerve distally till we see its bifurcation, where it gives a superficial sensory branch and a deep motor one, which continues as the posterior interosseous nerve, and this nerve may be entrapped between the two heads of the supinator muscle at an area called the arcadophros. This is the radial artery. This is the normal appearance of the posterior interosseous nerve, where it passes at the region of the arcadophros between the two heads of the supinator muscles. We notice here the normal uniform thickness of the nerve at cases or in cases of entrapment. We will notice that there will be increased thickness, or the nerve will be edematous proximal to the entrapment site. Then finally, we examine the posterior aspect of the elbow joint by asking the patient to bend his elbow at this position. Then putting the probe LS, where we see the triceps muscle and its tendon. This is the fat pad at the posterior elbow. There are two potential spaces, which are the superficial bursa, where bursitis can be seen here, or the deep one, where bursitis can also be detected here. This is an example of the biceps rupture, where we see here the biceps tendon with the torn fibers, hematoma formation. And this is another view where we see the retracted fibers with the hematoma formation. While in this image, this is the normal appearance of the biceps tendon. Here, this is an example of a collateral ligament injury or tear, which in this case is the radial collateral ligament. We see here fluid at the site of the ligament. Also, we can see here the torn fibers of the ligament at each side. Overlying it is the common extensor tendon, which we see here is a normal appearance with no affection. Then we move to the tennis elbow, which is the tendinopathy of the common extensor tendon, previously known as the lateral epicondylitis. Here we see that there is increased thickness of the tendon with the altered echogenicity, areas of hypoechogenicity, and increased vascularity on Doppler study denoting tendinopathy. Also, some partial thickness tears may be seen in some settings. This is another example of tendinopathy with a partial thickness tear. At the medial aspect, the tendinopathy of the common flexor tendon is known as golfer's elbow, um, or a misnomer also known as medial epicondylitis. We notice also increased thickness of the tendon. We may see altered areas of altered echogenicity, some calcific foci in chronic setting, and increased vascularity. Regarding the ulnar nerve dislocation, we put the probe at TS in the cubital tunnel and ask the patient to do a flexion and extension of the elbow joint. At this point, we observe the nerve and we see whether it dislocates from its place or not. Here, this is the normal appearance of the nerve in its side. We'll do the assessment by flexion and extension. We notice here that it is dislocated outside the normal position. Another pathology seen in this region is the snapping triceps syndrome, which may occur with the ulnar nerve dislocation. Here we see the nerve at this normal side, then the nerve will dislocate, followed by the echogenic triceps tendon. Then returning back to a normal position. Moving to the posterior interosseous nerve entrapment at the archetophosh. This is the normal appearance of the nerve, where we see it passing between the two heads of the supinator muscle, and this is normal appearance of the nerve in TS examination. We notice here at site of entrapment there is increased thickness of the nerve with entrapment on this side between the two heads of the supinators at the archetophosh. Also in TS we see the difference between the normal side and the abnormal side. Moving to the posterior elbow pathology, we can see triceps tendon rupture with the hematoma, or simple tendinopathy, which may be also a calcific tendinopathy. At this region also we notice the Olecranon superficial bursitis, which is very common to see. Also not to forget the deep Olecranon bursitis. Thank you very much.